This is a 26-year-old female who's come to visit us in our office. She has not used any drugs in the last 12 months. She started snorting and injecting when she was 19, and she stopped both of them when she was 21. She's, to the best of her knowledge, never had any blood products or blood transfusions. She's never worked in a healthcare setting. She says that she's probably had sex with somebody who's had Hep C, and that in the past she's probably shared some personal items as well. She has 5 tattoos. Some of them are unprofessional, and she got like her first one when she was 16, and that was non-professional. And then she's never been to jail. She was first diagnosed in 2012 at the hospital, but she's never had any evidence of decompensation or any evidence of cirrhosis. She's never been treated, never had a liver biopsy. She really doesn't have any other medical complaints. She has been vaccinated for Hep A and Hep B and is immune to both. She does endorse a history, though, of depression and anxiety. She does follow with psychiatry, where she gets Invega. There's some question as to whether or not she's bipolar. If she is, she's probably a bipolar 2. She denies drinking any alcohol. She is not currently using any drugs. She does smoke. She says she smokes, though, only about 2 to 3 cigarettes per week. Her only medication at the moment is Invega. Oh, and then she also has the Depo-Provera for birth control. She is only about 5'3", and her BMI is 21.6. Her lab work, her creatinine is fine. Her liver enzymes are marginally elevated at 30 and 36. Her GGT is good at 24. Her GFR is 113. Iron stores are appropriate. Her vitamin D is good at 46.6. She's genotype 1A. Her viral load is incredibly low at 5,090. Her resistance testing is negative. Her Hep B core is negative. Her liver ultrasound is normal. And on FibroScan, she was an F0 to F1. And her steatosis score was S0 to S1. APRI is 0.463. FIB4 is 0.38. Child Turco-Q is an A. And her MELD was a 6. And that's pretty much her.
All right, thank you so much for that. Did anyone out there have any comments or questions about that case?
Are you taking the lead over there? You taking the lead over there?
I can, yeah.
Does she have a thought process as to what she wants to do first?
Yeah, so sure. Did you have any questions about you know, who, sorry, Dr. Tierney, what do you want to do with her? Yeah.
I'll treat her with Mavorite for 8 weeks.
Okay. Yeah, so I mean, yeah, I was like, you know what you're doing. The Invega, because I was just checking, because I'm not as familiar with drug interactions, and it looks like there may potentially be with both Mavorite and Harvoni,
Okay.
but it doesn't look like it's really been studied. So I wouldn't necessarily, it just says a potential. So I wouldn't necessarily feel like you need to avoid it. If I pull it up, it just says, just because Invega is primarily eliminated renally, CYP3A4 and CYP2D6, and may increase those concentrations due to PGP inhibition by Mavorite, but no clinical significance known. So
Okay.
I think you'd be okay with that. It didn't look like there's anything with the Epclusa, which is the, the 12-week course versus 8. So I think you'd be fine with either.
Okay.
Did anyone else have any other comments or questions? You guys are more than welcome to chime in if you have any comments. All right, well, Dr. Tierney, was everything answered as far as that case goes? And
Yes.
did you have any other questions or anything?
I don't.
Okay,
But
perfect.
that was good information on the Invega.
Okay, absolutely. Sounds good. So if you don't mind, we actually don't have a didactic today, so I was thinking of maybe going through all the cases that we had submitted. I know, Dr. Peters, you joined us, so I know you have some submitted as well. I saw you submitted some last night as well, and we didn't get to format those ones quite yet. So some of the ones from last time, do you want to go for any of those ones in particular? I can pull them up for you.
Sure. Yeah. Let's do 4689. If you've got that one there, is a 52-year-old female.
All right.
Of all the cases, she's probably the most interesting one.
All right, perfect.
So this is a 52-year-old white female that I saw originally, actually about 1.5 years ago, as a consult to see about getting her treated for her hepatitis C. We began that process with her kind of moving forward. We never got to the point of presenting her though, because she suffered a CVA. So she had a stroke and was really, really sick in the hospital in the hospital and then recovery afterwards for the better part of 6 months. And she's kind of gotten herself stable from that standpoint, and now is interested in pursuing again, getting treated. So she is a, like I said, 52-year-old white female. As far as her Hep C goes, she's a 1A and an F3. Her viral load is about 3 million, just over 3 million. She's HIV negative. She's had the vaccine series for both A and B, and is immune to be confirmed with labs. Her basic labs are relatively straightforward, and they're there. What's interesting with her, so 1.5 years ago, she was an F3, and then a few weeks ago, she's an F3 to 4, relatively stable. She doesn't appear to have any signs of decompensation or anything that I'd be concerned about. The only exception to that was her AFP was elevated. I went ahead and repeated a right upper quadrant ultrasound for her, which wasn't terribly remarkable for her, other than showing, well, it didn't show any evidence of tumor or cancer. She does, however, have neurofibromatosis. So I guess my questions really for her was, does this in any way change, treatment, treatment choice for her, or monitoring? With her being an F3 or above, she'll need ultrasounds every year, basically, to screen for hepatocellular carcinoma. But in the setting of a patient with neurofibromatosis, I don't know if it would need to be done any more frequently. Would she need to be every 6 months? Would she need to be every 3 months? Should it be followed with serial biomarker? Is there anything in particular that would be the case, or would there be any drug-drug interactions that would make Mavorite an unreasonable choice for this patient for 8 weeks, which is what I had thought about recommending for her.
Thank you so much.
You bet.
Did anyone need to see any of the other labs? I can move it up. Anyone out there?
Are her meds listed there? Okay.
It should be the last page there. So she's on Keppra. And keep going if you wouldn't mind scrolling a little bit more. There we go.
Good, thanks.
Yeah.
Interactions of concern.
You want to start? You want to start?
Feel free.
You just came in. I'm sorry.
Sorry.
Greg, it's Kaylee. I think Maverick would be fine for her. I don't see any issues with that, even with the NF1. So, I mean, typically, I think even with neurofibromatosis, I think the hepatic implications would be pretty rare. So
Right.
I mean, I think you could still just do ultrasound screenings every 6 months as far as HCC screening. And I mean, I was pulling up a study earlier today, and it just says it's extremely unusual to have tumors in those locations. So, you know, if you note any abnormal findings on an ultrasound and as far as lesions or masses, I mean, you could certainly consider further workup at that point. I don't know if you have any other insight as far as
None in terms of neurofibromatosis.
yeah.
Way to stump us, man.
But yeah,
Thanks.
I like that. We don't talk about that very often.
No, but you know, I think Kaylee and I both have a super low threshold to. I feel like we've seen a lot of HCC lately. Just with that alpha fetoprotein, my threshold to MRI is like already been met, if you want. with a, I didn't do the APRI or anything calculation in my head, but it looked like it'll probably be okay. But she's got fibrosis. She might have some genetic predisposition to forming tumors. I know, obviously, nerve sheath ones, but Lord knows how that translates when you throw Hep C in the mix. So I don't know. I probably would have really low threshold to image your liver better with that 28 AFB. Yeah.
I would definitely get a triphasic imaging as well. Nothing without contrast.
Would you go MRI?
Oh, MRI is fine, yeah. But I mean, I see a lot of I don't know who from, but I see a lot of CTs without contrast come through of the abdomen. They're not sufficient for the liver to look at HCC. They have to have contrast.
So in this page, so would you do it with and without contrast then with an MRI?
Yes.
If you're, I see.
Yes.
Okay.
And hopefully it'll show nothing and life will be good. Yep.
Great.
Love your Maverick choice. I think it's good. Yep. And Rachel here did the interactions for us, and it's good. She whispered it in my ear. All is good. Yep. Yep. Good stuff.
Did anyone out there have any comments or questions about this case? You can also chat us on the side if you'd like. Well, we actually had one more case submitted from Dr. Bailey, who I don't think can join us today. So it's Dr. Peters and Dr. Tierney. You two have submitted some more. So if you'd like, we can absolutely go through. I was hoping to circle around so everyone got at least one case in. But since we don't have a didactic today, we could absolutely rotate between the two of you.
Well, if Greg has if he has multiple, let him go ahead.
Sure. Are you okay with that, Dr. Peters?
Yeah, man, I'll talk all day. Whatever y'all need. Now I've got a 26-year-old female that I'd like to present next. Let me see if I can find it too. Yeah, I've got her here. Let me make sure I've got a couple of 26-year-old females actually. That's this one. So this lady, I'll just keep it just with her. So she's actually married to one of the people that I submitted day before yesterday. I hadn't seen him yet. And then he came into established care. That was actually kind of why we submitted. Both of the cases that we submitted are married to other cases that we had already submitted, I guess, if that makes any sense. But there's two, we've right now got 4 married couples pursuing treatment together, which is kind of odd. We've never done that. One of the couples has different insurance too. It's just kind of, that'll be someone else's problem to deal with, I'm afraid. But so this is a really nice 26-year-old young lady who has hepatitis C and I've been following now for a couple. She's, I think, kind of highlights what I think Dr. Tierney and I have been watching for really years. Like she's somebody that I've been monitoring, acquired hepatitis C through IV drug use years ago, has been sober for years, has no evidence of badness, and now is ready to get treated. She's got Medicaid. She's had the hepatitis B series. She's immune by lab. She's had one of her hepatitis A vaccines. We actually just recently gave her the second one, so she's up to date on that. Her labs are really relatively unremarkable, other than a elevated ALT at 110. She's negative for everything. Her viral load is less than 1 million, and she's an F0. Her most recent viral load, when we submitted the case, was old. It was more than 6 months old, and then she came in. We got a new one. It's still below 1 million, and we're planning for Mavrite for her for 8 weeks, for Epclusa for 12, but we'll probably just stick with Mavrite for 8. Her medications don't look like anything that should pose any sort of a problem. She's on Lexapro and is doing well, actually. She really is in good spirits and doing well. She's working, and is relatively straightforward. So I think she's somebody that we recently started her on birth control also. That was the other thing. I should have made a note of that. And that's it for her. She's relatively straightforward as well. So I was trying to think if there was something. Her husband is probably the person that she contracted hepatitis C from. He might end up being a little bit more interesting. His stuff, there's a couple of things that are still pending on him. He is a 28-year-old gentleman that may have had hepatitis C for a long time. His mother has hepatitis C, and he says he had been told early in life that predated his IV drug use that he had hepatitis C. So he may be somebody that's actually at 28 years old had it for 28 years. So we'll see if that's the case. I've yet to find somebody like that, so we'll see if he's the first one. But.
What kind of birth control is she on, Greg? What's her contraception?
Pull it up. I'm sure it's some monophasic birth control pill. To make it simple, let's see.
And Greg, while you're looking that up, I think Rachel, do you want to share or do you want to talk about it? Okay.
Yeah, there's a drug interaction. Well, it's a contraindication with Mavrite and any birth control that contains ethinyl estradiol, which is the majority, almost all of the combined oral contraceptives.
Yeah. It's an IUD, actually. I'm sorry.
Oh, okay.
You're good.
Never mind.
I was thinking I'd thought of that. It was yeah.
That might want to push it towards Epclusa otherwise. Yeah. But yeah, no interactions with an IUD that I'm aware of.
Yeah. So. Sometimes with couples, I'll kind of give them the option if they want to just wait on each other and just start treatment together. That way they're.
Yeah, that's what's interesting about him. So there's going to be I can't imagine at least that there's going to be any chance that I'm going to be able to dig up an old viral load of 6 months or more. You know, I mean, hopefully, but I can't imagine that's the case. If that's the case, then his treatment's going to be stalled for 6 months while I wait to get a second one.
And sometimes I run into that where patients kind of new to me, but they've been told they had a diagnosis at some point. And Medicaid will require it if it's a new diagnosis. And I've been denied on the initial PA if I don't have those 2 viral loads, but then I've been able to appeal on the grounds that this is actually not a new diagnosis. We just aren't able to obtain. So you might be able to, if they're both ready and
yeah,
both
sure, it wouldn't hurt my feelings to do that.
I mean, either or. It's just sometimes the couples are like really wanting to do it together, and then they're, you know.
Yeah, I think the patient I just presented, she's ready to get treated, and he's thrilled that that's even a possibility. They didn't even come in for this, you know, when we talked about she just came in for just normal, regular, routine, boring follow-up, and I asked her, you know, would you be interested in doing this? And she said, oh yeah, and you know, my husband's never seen anybody because, you know, what X, Y, and Z.
Sure.
So it's yeah. But
and you may even be able to, if you end up, you know, trying to appeal him to get him sooner, I mean, you may be able to justify further since, you know, she's pursuing treatment, just try to eliminate transmission risk between them again. I mean, I think you could work around it. You could work your magic. Be able to do it.
I've had some success doing that, so it's I feel confident we could.
Cool.
We don't talk about birth control very often, but I remember that with the Rachel always reminds me of nothing with the PIs there. So be careful.
And I want to point out, just because this is a personal kind of mess up I'd had. So I mean, she's got an IUD, but I had a patient that had she was pregnant when she established with me, and so waited until she delivered, was done breastfeeding, came back into care for treatment, went through the whole, you know, could you be pregnant? We did a pregnancy screen at her visit. It was negative, all that stuff. And then she actually there was a little bit of a delay in her getting it sent to her, shipped. So the day before she was supposed to start, she called in and had a positive home pregnancy test. And so this is like, we have counseled, she's like, no issue, we're not gonna have sex, all this stuff. And then she fortunately had checked at home, but like when I saw her 3 weeks prior, like she was just coming off of her period. We did the pregnancy, you know, I mean, so it's just something, if there happens to be a female of childbearing age, I've learned, and they're not on, you know, contraception or maybe questionable, it may be worthwhile just repeating a urine pregnancy right before they start. So she'll be able to get treated. She's just gonna have to wait a little while now.
Yeah.
But that's kind of my personal, I'm changing practice because of that one.
Did anyone out there, sorry, Dr. Peters?
Oh no, go ahead. Go ahead.
Yeah, no, I was just going to ask anyone out there had any comments or questions regarding this case or some of the discussion that's been going on.
Yes, I do have a question. You said there's no interaction with the IUDs. Does that include both the copper ones and the hormonal ones, like the Mirena?
Correct.
Yeah, okay. So the hormonal ones they're progestin only, drug eluting, so they're fine.
Thank you.
You guys have any other comments or questions?
No, proud of you guys. Good job. Yeah.
Awesome. All right, great.
No, Dr. Bailey.
I know.
No.
Did Dr. Bailey have a Hep B case?
Yeah, she
Oh,
had a Hep B
man,
case.
there was a cool case pending, but we're gonna wait.
We gotta wait to hear all her information, but it was a good, interesting one.
I should have mentioned just for review. Actually, that lady that I just presented, her Hep B core is positive for her as well, but she is immune. So she's one of those people that had it, cleared it, is immune to it.
Right. Very cool.
All right, well, I know there's one case left for both of you. Dr. Tierney, did you want to do one? And then we can go back to Dr. Peters' last case as well.
Sure.
Okay.
This is a 21-year-old gentleman who's coming to see me. He did some injection drug use for about a year, but he has stopped 4 years ago and is currently in a Suboxone clinic and is doing quite well with that. He's never had any blood products or blood transfusion. Doesn't think he's ever shared any personal items. Not sure. He has one tattoo from when he was 16 and he's never been to jail. He was diagnosed in June 2018. No evidence of any decompensation or cirrhosis, other than a substance abuse and some psychiatric history, depression and anxiety. He really doesn't have any medical diagnoses. He's in the process of getting his vaccinations for A and B. And like I said, he has depression and anxiety, and he does follow with psychiatry and has a counselor. Not drinking any alcohol. Like I said, the only medication he's taking that's a substance use is the Suboxone from medication-assisted therapy. Smokes a half a pack a day. He started when he was 15. So he is taking buspirone, fluoxetine, mirtazapine, all from his psychiatrist, and Suboxone, and I have him on vitamin D. His BMI is 40, almost 41. His labs, he does have some elevated liver enzymes, but his kidney function is good, iron is good. He's type 1A, viral load is 714,000. He's Hep B core negative. His surface antibody is non-reactive and his surface antigen is negative. His APRI is 0.7, FIB4 is 0.53. Class A with child Torco-Q, MELD is a 7. FibroScan shows him to be an F2. Ultrasound does show generalized fat in his liver, and that is our young gentleman. And I'd recommend Maverick for 8 weeks.
Thank you for that. Did anyone have any thoughts on that case?
We're working on the non-alcoholic fatty liver stuff too. Weight loss.
Sure you. Thanks, Dr. Tierney. That's perfect for him.
Amazing for his age.
Yeah.
All of the evil going on. I have a hard time buying that he's just an F2 or an elevated APRI from just Hep C, obviously.
Yeah. Yeah.
The other stuff going on.
Yeah.
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 Good benefit to him to get him treated ASAP,
Yes.
and certainly from a regimen standpoint, sky's the limit. But I think that your choice is perfect, and interested. Probably want to just follow his fibrosis scores too going forward.
Absolutely.
Unrelated to his Hep C, just to make sure things don't end up in a bad way. From the hepatology standpoint, any thoughts?
No, and genotype 1 doesn't put fat into the liver. Genotype 3 will. But for him, you know, short of other metabolic components, that really just weight loss and dietary changes is going to benefit him in the long run.
Mm-hmm.
Let him know that fatty liver is going to be the #1 reason for a liver transplant. They're expecting.
Oh, yeah.
That's terrifying.
Yeah, it is terrifying. And his BMI would have to be under 40 to be considered.
Terrifying because we don't have good treatment for it.
I know.
That's scary. But yeah, F2, that's interesting. Very interesting. Yeah. Physiologically 41 or yeah, whatever.
Yeah.
But great job. I think you can get them treated and Mavorite and see what happens. Be fun to follow that fiber scan with time and see what happens. But just more proof that these non-invasive markers are not, you know, as specific for Hep C as we pretend. So, but good job. Yeah.
Thank you.
All right, any last comments or questions on that? I wanted to ask everyone out there as well. All right, well, the very last but not least case, Dr. Peters, we can pull that up for you if you'd like.
Sure. I'm actually having a tough time finding that sheet that you sent me. I'm trying to think of who this is.
I can try to email it over to you as well if you'd like.
If you don't care, let me see.
Can you see this okay?
Yeah, that's so 28-year-old.
Maybe that's the husband. No, never mind. It's a female. Yeah.
Yeah, man, I'm embarrassed. I thought I presented this last week. Yeah, I feel bad. All right, well, yeah, so we'll do that. That'll be fine. Okay.
No worries. I can email it to you as well, just so you can have it on hand.
Let me double check. Let me double check this real quick because that's who it's got to be. All right, so let me pull this up. So we got 1, 7, 7, 0. Sorry about that.
Okay, so I just emailed it to you. Let me know if you get it okay.
Okay. All right. I'm gonna pull up her viral load just so I'm sure. Is it like 2.5 million? Can you go down before I do
Yes,
that?
it is.
2.5. Okay, that's who it is. All right, that's fine. So yeah, so this is a 20. This is another. This is just like the last. This is kind of the same story, right? So a 28-year-old female that's been waiting for treatment for a long time, just had her second hepatitis A vaccine when we discussed the fact that we can get her treated. She came in for another reason, just to talk about, I think it was allergies or something, like something silly, right? So no big deal. Oh, by the way, did you hear the law changed around medicines? Oh no, I hadn't heard that. That's great. You know, and she's actually somebody who says her significant other who accompanied her has hepatitis C. He's never been worked up, so I don't know if he's like in the same place that she is as far as wanting to pursue treatment. The counseling that I gave her was really that you get kind of one shot at this as far as that goes. And so, you know, if you're in a situation where, you know, treatment is not right for you at this time, but, you know, might be right for your partner in the future, the timing surrounding that is something we have to be very careful about and judicious about when to use the medicines. Her labs are really straightforward. I mean, she's you can see her there. There's her transaminases are normal, or she is HIV negative. She's had the vaccines. She's pretty well good to go. I was going to recommend Mavorite for her also.
Greg, this is John. I would also advise maybe some Allegra for the allergies because
that's a good choice. It's you know, what's interesting actually, what I talked to her about was she's on Suboxone, so she follows with an MAT program outside of
that'll soon be you, right? You'll be a one-stop shop, right?
Right. You know, one of the things that I talked to her about is actually I don't think she's got allergies. I think what she's doing is she's going through withdrawal from her Suboxone, like her dosing of Suboxone. I think it's just starting to come out of her system.
Gotcha.
When she then redoses, and these people will get this kind of reactive they just get this clogged nose and sneeze and itchy, watery eye, that sort of stuff. They take their Suboxone and it gets better. And I think that's actually what's happening in her. I don't think she has allergies at all.
Interesting.
But I did not recommend more Suboxone for her. I'd have to defend that, I'm afraid, in court. But no, she's
straightforward.
Relatively straightforward lady that I think you could choose anything for, and it would probably cure her. So,
Speaking of which, as Gilfu's here at the hub, do you guys, if anybody has any, you're all such advanced prescribers now. Does anybody have, if we have any cases of treatment failures, those would probably be fun ones to bring up. I know we usually talk about treatment successes or treatments that are pending treatments, but if anybody has any treatment failures, I think we're ready to go there if anyone has those. I hope we don't have any, by the way. I would love to never have any. There's got to be a 1% somewhere though, which is the numbers we're playing. So, but great job, Greg. Yeah, way to transition the visit into something that we are more interested in. I do that all the time.
yeah, that was exactly what it was. It was, hey, so-and-so. So, your stuffy nose is boring, but I thought maybe we can fix your liver. Nobody ever cures allergies, but we can cure Hep C. It's pretty cool. So.
This is Kaylee at the hub real quick too. I just want to plug in our on-demand echo again too, just because we're having such increased access to treatment now with these restriction changes, and so we may not get through as many cases in our learning sessions or live sessions. So if any of you guys have a case that you just want to kind of have our blessing on, or just send to us through the on-demand, we can respond. I asked for like a week's time, but usually we can turn it around faster than that. That way you don't necessarily have to wait till the live sessions to present, which we still obviously want the cases to discuss during our sessions, but just for the sake of being able to get through them, if you'd like that, that's another option. And that's not just for everybody that's been doing this for a while too. Even if you haven't presented a case yet, but just kind of want to throw one out there, that's an option for anybody.
I can tell you, I really appreciate that. That's great. I've got 6 more.
I figured, yeah, I know. I'm sure you guys have like so many that are.
That's going to be really helpful. Really helpful.
So we'll be able to get a response back. And if you put down kind of your thought process, like this is what I'm intending to treat with, is this okay? If you put your questions at the bottom, that way we can just go ahead and address those directly with you. That's fine, but I think it's the same format. It's just the little drop down box instead of you click on demand. Is that how it looks on?
So we usually just say at the bottom there's like a comment section or further questions. You can just type in on demand. You could also email it to myself or Caitlin, and we'll make sure to have them sent to Kaylee and Dr. Gilfus. Thank you guys.
So, and the goal would be to present them eventually, just because we still want to present the cases, but this is more just as an expedited echo session, I guess is how I'd phrase it. One-on-one echo.
All right, did anyone have any comments? If you have any questions about on demand as well, you can certainly ask about that.
Would you guys have time for an unrelated question, something just kind of general infectious disease oriented? Do you care?
Yeah.
There's 2 that just real briefly. So I get asked about coronavirus like every day, like a bunch, just because people watch the news and stuff. And so I was just kind of curious, I don't know, what the 15-second spiel would be that you would give people surrounding that, aside from travel history and that sort of thing. The other question I have is actually the interesting one that came up. I had a colleague ask me, in adult patients with exudative pharyngitis, right, and let's say you do a rapid strep test that is negative, right? And in adults with significant comorbidities, to what degree would you feel compelled to treat that, like thinking about other forms of infections, like not strep, obviously? So things like anaerobes and that type of thing, with like a COPD patient that's a smoker and those sorts of things. Like, And I honestly had never really thought a whole lot about that. Like, it was just sort of, you got an adult, you don't think it's strep, it's probably viral, it's probably EBV or CMV or something else. That's not a big deal. You just watch them and they get better and they do well. But I guess this kind of came up, and I just hadn't really thought about how to think about that exactly, and I was kind of curious what you guys thought.
Yeah, I mean, I'm to answer the first one, you don't want to talk to me about coronavirus. I tend to be a doomsday guy. I'm, no, but I guess the only thing I'll mention about coronavirus is the BioFire. If y'all have a BioFire test available, it's not that coronavirus. So, that's not the test for it. Our lab and the state health department had wanted us to advocate that knowledge to be expanded. So it's not going to be the coronavirus that's positive on the BioFire. But otherwise, man, it's scary. Genuinely, I don't know. I'm probably the wrong one to talk about it. I mean, 2% mortality scares me when we talk about a new novel virus, and I shouldn't go much more into it. But yeah, we'll see what happens. We'll hope it doesn't become what everyone thinks it will. And with regard to the exudative pharyngitis, I've been internist to the core there. In other words, I contemplate diagnostics and not any therapeutics. So I don't think you need to treat if it's strep negative, but you need to approach it from a what is it standpoint, because it can be anything from initial presentation for an STI. We've seen exudative pharyngitis from syphilis, and to if it's an immunocompromised patient, fungal infections. So we really, and like you said, Greg, some of the other viruses, we in general just use the word virus, but HIV is a virus, and so it can cause the pharyngitis. So the diagnostician should probably take over when the strep is negative, above offering real therapeutics. Are there some non-group-based strep bacteria that can cause pharyngitis? Sure, yeah, there are, but none that in general are worthy of empiric therapeutics, at least in a normal patient. Even one with diabetes. I know with people who have diabetes, we tend to be more lenient with sinus infections and ear infections, and I think that's justified. But in general, I don't think equal leeway is required for a patient with a pharyngitis. More diagnostic thought process. I can basically through almost every category of pathogen and think of something that can cause an exudative pharyngitis. So looking at the patient, their travel history, their exposure histories, their sexual histories, etc., and more. If you strike out there, you're probably okay to just wait and do nothing. Yeah, but great question, man. Yeah. When as an internist never said diagnostics isn't the answer, right? We don't offer. No one ever leaves feeling better, but with a lot of questions answered. If they
well, the family medicine response is you just wait and see if it gets better, and then, and that's that was how this came up. Was she's one of my very good friends. We graduated from residency together, and she asked, what do you do? And I'm like, I don't do anything. And they all I don't know, it's not strep, and like and it looks fine, and as long as they don't look like they're getting really bad, you just kind of watch them, and then a week later they're all better. I don't know, I've never had any other problems with it. So,
I think the STIs are the main ones to really, the probably syphilis is the major one that we had a weird case of that a couple of years ago. But the HIV is always one that they say is not an exudative pharyngitis, but I'm never sure how much the virus reads the book on that one. It's a pharyngitis.
Well, I feel real bad about coronavirus now. I have to go dig off
it's just scary.
I got to go dig a shelter now because if John's scared now, I'm not going to sleep tonight. That's not good because
I'm 100% on the phobic end of life. I'm just not. I've seen too many young people on ECMO in my career from viral infections, and the thought I'm having another novel virus that can send people into ARDS is frightening, and the number 2% is never comforting to me from that perspective. But I hope it's fear greater than reality. Hope so. Yep. And the BioFire is not, don't worry. I had like 10,000 phone calls about BioFires being positive the first week. So, but it was, it's not the same. It's not how you test for this coronavirus.
Are there any final comments or questions? We have about 10 minutes left for this session. Again, it doesn't have to be related to the cases that were presented. Anything you can certainly ask.
It's kind of related to what Greg was saying. I had a lady this week, an adult who is a teacher in an elementary school, negative strep test, sore throat, looked bad, didn't treat her, but she kind of demanded to have a mono test done because she had mono when she was a teenager. And so I get it back. Her IgM is negative. Her IgA is something like 500. I don't know that I'm going to do anything with that either, right?
No, 100%. So if I despise EBV serologies. The most important thing to look at is the EBNA. The nuclear antigen is positive. It's not acute. Whether the IgM and IgG for the VCA can fluctuate and oscillate, and I don't even look at the numbers. It's just, in my mind, they're qualitative tests if positive, and you just look for, if EBNA is positive, it's not the answer for what's going on right now. And so that's the easy, quick interpretation of EBV serologies. Look at that EBNA, the EBNA. Yeah, and because boy, they're even the interpretation the computer gives is confusing. But if you just think about that, the nuclear antigen takes time to be expressed and then developing immune response too. So if that's positive, you're good to tell the patient with confidence that their current illness is not EBV related. So, or their current pharyngitis is not EBV related. It's unfortunate I've seen the IgM VCA antibody positive in the chronic setting, so it's frustrating. DNA is a very expensive alternative if you wanted to order that, but I wouldn't advocate it routinely because it's pricey and as with any herpes virus, if you're acutely ill from something else, you can on occasion get low-level reactivation, and so I don't want to. I think it can add more diagnostic confusion. So, but yeah. Stupid serologies. Hey. Requiring us to think all the time.
All right. Well, thank you so much, Dr. Tierney and Dr. Peters, for all the wonderful case presentations. We really appreciate it.